Hello, good evening everyone. Welcome to the UPSC CMS 2023 Emergency Medicine a quick webinar. If you see, emergency medicine is one of the most important topics in on the paper one. If you see from the paper one, 96 questions of from general medicine. They also mentioned like very clearly emergency medicine, common poisonings, snake bite, tropical medicine, critical care, and all these things are very important. The session on emergency medicine, common poisonings, snake bites, and critical care medicine, each you will get in your examination. At least if you see in the last 5 years trends, at least 2 questions and sometimes 3 questions particularly to the poisonings, and one question at least from the snake bites is there. From emergency medicine, 2 to 5 questions, and critical care medicine, 2 to 4 questions were there across various examinations. So this is one of the very high yielding topics. Though it takes very less time, you will find it very useful. So we'll have a quickly we'll have discussion about few very most important topics. Then coming to when it comes to emergency medicine, the American Heart Association guidelines are very important, which covers basic life support, advanced cardiac life support, BLS, ACLS, advanced cardiac life support, and post cardiac arrest care. So what are the most important changes? The recent changes came in 2020. So all the changes are we have to remember them very carefully. So what is IHCA and OHCA? IHCA is in-hospital cardiac arrest. OHCA is out of hospital cardiac arrest. What is the change? The most important change is the recovery component has been added. The recovery component has been added to the in-hospital cardiac arrest and out-of-hospital cardiac arrest, which is very important. Earlier, there used to be in-hospital cardiac arrest, the 5 steps: early recognition and prevention, activation of emergency response system, high-quality CPR, defibrillation, and post-cardiac arrest care used to be there. And now they added the recovery component. In out-of-hospital cardiac arrest, earlier there used to be 5 components: activation of emergency response system, high-quality CPR, defibrillation, advanced resuscitation, post-cardiac arrest care. Recovery component has been added. This is one point I want you to remember from this particular slide. Then coming to adult basic life support, what are the components in this and what are the most important things you have to remember? Quickly, what is the first step in BLS? That is verifying scene safety is very important. I want you to remember verifying scene safety is the first step. And then you check for responsiveness, shout for nearby help, activate emergency response system, and then ask them to get an AED and emergency equipment if it's available. And then you check for breathing, respiration, and pulse. So what is the maximum time you can spend? The maximum time you can spend is 10 seconds. And the most important change is whenever you are in doubt whether the pulse is there or not, go ahead. Don't wait. When you are in doubt, go ahead with CPR. This is again an important point. Then if there's a normal breathing and pulse is there, you monitor until the emergency response system arrives. If there's no normal breathing and pulse is felt, so provide rescue breathing, 1 breath every 6 seconds. So this is one, again, most important change, 1 breath every 6 seconds. So that is 10 breaths per minute. This is the again most important change. In the previously, when you go to 2015 guidelines, they say like 1 breath every 5 to 6 seconds, that is going to 10 to 12 breaths per minute. Here they made it categorically very clear, 1 breath every 6 seconds. So this is one important change. And if possible, if you suspect like opioid overdose, then you administer naloxone. Okay, naloxone you can administer. The only drug of mention in the basic life support is naloxone. Then there's no breathing or only gasping is there and pulse not felt, then start CPR. How many times you have to do that? CPR per minute you have to do 100 to 120 per minute. And how much depth? 5 to 6 centimeters. Otherwise in inches, 2 to 2.4 inches. This is very important. And once you start doing CPR, AED arrives, you check the rhythm, whether it's depending on shockable rhythm or not. What are the shockable rhythms? What are the 2 shockable rhythms, or what are the 2 non-shockable rhythms? The shockable rhythms are ventricular fibrillation and pulseless VT. What are the non-shockable rhythms? When it comes to this, what are the non-shockable rhythms? Non-shockable rhythms are asystole and pulseless electrical activity. So these are two shockable rhythms and two non-shockable rhythms. What is the dose? What is the shock? How much amount of joules you have to give it? In shockable rhythms, when you are giving it for biphasic, you give 120 to 200 joules. For monophasic, it is 360 joules. 360 joules. So the important points in this: first step is verifying scene safety, and then you have to check for call for nearby help and then do that. The maximum time you can check for pulse is 10 seconds, and the respiratory rate in respiratory arrest is 1 breath every 6 seconds in adults. And what are the shockable rhythms? Ventricular fibrillation, pulseless VT. Non-shockable rhythms are asystole and pulseless electrical activity. The CPR, how much you will do per minute? 100 to 120, and 5 to 6 centimeters. This isn't change. Earlier they used it to say that 100 per minute and 5 centimeters. In the 2020 guidelines, they clearly change 100 to 120 per minute and 5 to 6 centimeters, or 2 to 2.4 inches. Then biphasic and monophasic energies is 120 to 200 joules biphasic, and monophasic is 360 joules. Then BLS and do's and don'ts of high quality CPR. Rescuers should perform chest compressions at a rate of 100 to 120 per minute. Compression at depth of 2 to 2.4 inches, that is 5 to 6 centimeters. Allow full recoil after each compression. Minimize the pauses in compressions. Interrupt compression for greater than 10 seconds should not be allowed. And ventilate adequately, 2 breaths after 30 compressions, each breath delivered over 1 second, and each causing a chest rise. And excessive ventilation should be avoided. Okay. Then coming to this adult cardiac arrest care algorithm, here you see once the patient is in a level 3 ambulance or taken to the hospital, then what are the things you do? Start doing CPR, depending on whether rhythm shockable or not. If the rhythm is shockable, then you do the similar thing. Give the shock, continue CPR, rhythm shockable, then shock, epinephrine, shock, then amiodarone or lignocaine, and treat the reversible causes. Here you have to remember, so if it is a shockable rhythm, it will be like shock, you do CPR, shock, adrenaline, shock, CPR, amiodarone. Shock, CPR, adrenaline, shock, CPR, amiodarone. Like in that sequence you go: shock, CPR, adrenaline, shock, CPR, amiodarone. What is the dosage you give? The dosage of adrenaline is 1 mg every 3 to 5 minutes. So usually you say 4 minutes, roughly, you remember. Then amiodarone, how much? It is the first dose is 300 mg, that is bolus. The subsequent doses are 150. Then coming to lignocaine, you can give, instead of amiodarone, you can give lignocaine also. That is 1 to 1.5 milligrams per kg is bolus, and 0.5 to 0.75 milligrams per kg the subsequent doses. So this is how you give it. And remember, if it is a non-shockable rhythm, what do you do? Nothing. CPR, adrenaline, or epinephrine, you keep giving it. CPR, adrenaline, or CPR, amiodarone. This is very, very, very important. CPR, adrenaline, you keep going this. There's no shock. So till what time, like, you keep giving shock, CPR, adrenaline, shock, CPR, amiodarone, till the time the patient is, whether it has been a spontaneous circulation and the normal rhythm is restored, or it going to the non-shockable rhythms. Then reversible causes. Reversible causes we will discuss in a minute. There are among the reversible causes, 5H and 5T. You have to remember them at any cost. Like 5H and 5T are very, very, very important. One of the potential questions. So we'll quickly see opioid-associated emergency for lay responders. If you suspect opioid poisoning, you check for the responsiveness, shout by nearby help, activate emergency response system, ask them to get naloxone. If the person is breathing normally, you just, if the answer is yes, you prevent deterioration, reposition, consider naloxone, and you observe that. If the patient is not doing, if the patient is not breathing normally, go and start CPR. Start CPR. Don't wait till you get the EMS, all the support. This is for lay responders. Like there is someone is not well trained in that, or not a healthcare professional. Suppose if you see, compare this with healthcare provider algorithms, everything is same. There you check does the person have a pulse? If the patient has pulse, then you support the ventilation, open the airway and proposition, provide air rescue breathing, and then give naloxone. If it's not there, then start CPR. Use an AED. consider naloxone and all. So what is the most important thing you have to remember based on these things is, for a lay responder, if the person is not breathing normally, there's no need to keep checking on the pulse. If for a, in opioid overdose or in respiratory arrest, if the patient is not breathing normally, you can even start CPR. That means when you are in doubt, go ahead and do the CPR. This is one important change of the 2020 guidelines. Then adult post cardiac arrest care algorithm. This is one of the important things. See, post cardiac arrest care and recovery have been given phenomenal importance in 2020 guidelines. Once the patient got written off spontaneous circulation, ROSC is obtained, it is important to manage the airway and by early placement of endotracheal tube, and manage the respiratory parameters and hemodynamic parameters. What are the targets? Respiratory parameters, you start at 10 plus per minute, and saturation target is 92 to 98%, and PSCO2 is at 35 to 45 mmHg. PSCO2. Then how about hemodynamic parameters? Systolic blood pressure should be more than 90 mmHg, and mean arterial pressure should be more than 65 mmHg. This is the initial stabilization phase, and you get a 12 lead ECG, and you consider cardiac intervention if at all. After taking the initial stabilization, you take an ECG, and the emergent cardiac intervention is needed if there is a ST elevation MI, unstable cardiogenic shock is present in the patient, or mechanical circulatory support is required like ECMO. In those conditions, you need intervention. And then you have to check whether the patient is following commands or not. If the patient is following commands, is other critical care management like support management, like for other systems, you do that. If the patient is not following commands, that means if the patient is comatose, this is very, very, very important. You keep the patient in TTM, targeted temperature management. Targeted temperature management. What do you do here? You keep the patient for 32 to 36 degrees centigrade for 24 hours. And you get the brain CT, and you later you initiate EEG monitoring and other critical care management. This is very, very, very important. You intentionally keep the patient hypothermic. Okay. In this page, I want you to remember the hemodynamic targets and respiratory targets. Targeted temperature management, what is this, and what is the temperature? 32 to 36 degrees, 24 hours, and obtain brain CT. Then if you see this, the same thing. Initial stabilization phase, titrate for FiO2 for SpO2 90 to 98%, respiratory rate 10 breaths per minute, PaCO2 35 to 45 is the target. And here start TTM, begin at 32 to 36 degrees centigrade for 24 hours using a cooling device. Then regular rest all care, continuous monitor care temperature, maintain normoxia, normocapnia, euglycemia, EEG monitoring, all are fine. Provide lung protective ventilation, which we will discuss in the ARDS in detail. Then this is very, 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 very important. These are the reversible causes of cardiac arrest. What do you mean by this? If at all a patient, while you are resuscitating it in the BLS or basic life support or advanced cardiac life support, particularly when you are treating the patient, and keep checking for, in the ACLS particularly, you keep checking for, is there any reversible cause of cardiac arrest? The patient has hypovolemia, that means the patient in shock, hypoxia. So accordingly you treat this. If you treat hypovolemia by giving fluids, and if you treat hypoxia by giving oxygen, H plus ion acidosis, that means the patient in metabolic acidosis, treat with by giving sodium bicarbonate. Hypo or hyperkalemia. Hypokalemia means you admit for that, like you give more potassium, and hyperkalemia means you give the treatment for this like calcium gluconate, dextrose insulin infusions. Hypothermia, you increase the temperature. And similarly, like treat the tension pneumothorax, cardiac tamponade, toxins, coronary and pulmonary thrombosis. If at all, these are the causes which these are reversible causes of cardiac arrest. Very, very, very important. These are the reversible causes of cardiac arrest. These are the reversible causes of cardiac arrest. Very, very, very important. Hypovolemia, hypoxia, H plus ion acidosis, hypo or hyperkalemia, hypothermia, tension pneumothorax, cardiac tamponade, toxins, coronary thrombosis and pulmonary thrombosis. Then this one particular table is very important. If you see this, what is this? From return of spontaneous circulation, once the patient has written off spontaneous circulation, in the first 24 hours, 48 hours, 72 hours, and later on, what has to be done? So clinical management, targeted temperature management has to be done as soon as possible, and after that rewarming and bring it to normothermia. Then coming to imagine, first 24 hours head CT, and from second day to fourth day MRIs. Electrophysiology into SSCP, you do that. And clinical examination, when you suspect status myoclonus, EEGs can be done, and this is very important. Serum biomarkers, NSE, neurospecific enolase has to be done. Neurospecific enolase, NSE, which has to be done on day 2 to 3. So here, what are the things first point, targeted temperature management has to be done as soon as possible, that is within 24 hours. Head CT has to be done within 24 hours. And third point, MRI will be done from 2nd to 4th day. Then neurospecific analysis is this is the biomarker which can be done in 2nd to 4th day. If they ask what are the things that has to be done in first 24 hours, so the answer is TTM and head CT. So these are the 5 points I want you to remember from this particular slide. Okay, very important. Then adult bradycardia algorithm or adult tachycardia, what is this? Whether, see, bradycardia and tachycardia, when do you define this, and when do you call symptomatic tachycardia or symptomatic bradycardia, and how do you manage this? See, whenever the heart rate is less than 50, then you called as bradyarrhythmias, and you identify and treat the underlying causes, like maintain the airway and oxygen if the patient is hypoxic. See, usually respiratory arrest, bradyarrhythmias occurs due to what conditions? Whether it might be patient might be having MI, or it might be having having any hypoxia, or due to drugs predominantly like calcium channel blockers, XU dose, beta blockers, or in conditions of digoxins, or if the patient might be having hyperkalemia. In all these conditions, bradycardia occurs. So you keep checking for this 12-lead ECG, and don't keep waiting for this, and consider possible hypoxic or toxicological changes, that means any drug overdose. And persistent bradyarrhythmia is there. If there is any warning signs or like things which we have to worry about, like hypotension, acutely altered mental status, signs of shock, ischemic chest discomfort, acute heart failure. If these things are there, that is called as symptomatic bradycardia or symptomatic tachycardia. So if these conditions like very important, hypotension, in the clinical scenario, if they'll give the bradycardia with saying in the stem of the question, the patient also having hypotension or mental status is altered, is not, signs of shock is there, ischemic chest discomfort, acute heart failure, then what do you do? Is atropine. How much atropine you have to give? 1 mg every 3 to 5 minutes. 1 mg every 3 to 5 minutes you give it atropine. How much time you can give? You can repeat up to 3 times. If it don't respond even with that, if atropine is ineffective, then go for transcutaneous spacing and or dopamine infusion or epinephrine infusion. So you do that. And even with that it's not happening, then go for transvenous spacing. Okay, you know, like dopamine infusion dose is 5 to 20 micrograms per kg per minute, and epinephrine 2 to 10. That is normal. Then coming to adult, here in most important thing is, when do you call bradycardia? What are the drugs and what are the conditions where the bradycardia occurs? When do you call it as symptomatic bradycardia? What is the first drug? The atropine. What is the dosage? 1 mg every 3 to 5 minutes. If it's not effective, what do you go for? These are the 6 points you have to remember. Then coming to adult tachycardia with pulse algorithm, you call it as like 100 more or tachycardia when more than 150 is there. Then again same, identify and treat the underlying causes. And when there's a persistent tachycardia with these features, like again the same thing, hypotension, acutely altered mental status, when the patient has septic shock, signs of shock or ischemic chest discomfort or acute heart failure is there, then you see that. Then again in this condition with the persistent, this is called as symptomatic tachycardia. In the symptomatic tachycardia, you do the synchronized cardioversion. Synchronized cardioversion, you have to do that. And if there is a refractory if it is refractory, then consider underlying causes, and like you keep addressing and increase the dose of cardioversion. And then if symptomatic tachycardia is not there, then you check about wide QRS complex. If the wide QRS complex is not there, then it means it is a PSVT. The tachycardia is there, there's no symptoms, and this wide QRS is also not there, so narrow complex. Then PSVT, then give adenosine. Adenosine, usually the first dose is 6 mg and followed by 12 mg you give it. Then you also can give beta blocker or calcium channel blocker. If there is a wide QRS is present, then consider adenosine to give only in regular and monomorphic. Okay, otherwise you give, what are the drugs you use in wide QRS complexes with tachycardia with wide QRS complexes? You give the drugs procainamide, that is, these are the antiarrhythmic medications for stable wide QRS complex tachycardias. This is unstable, symptomatic or unstable. This is stable wide QRS complexes. What do you do? Procainamide, you can use amiodarone or sotalol. So the 5 to 6 points you have to remember here is, when there is a unstable or symptomatic tachycardia, you do the synchronized cardioversion, and if it is a narrow complex tachycardia with no wide QRS, then you do the vagal maneuvers in the adenosine 6 mg followed by 12 mg, and beta blockers or calcium channel blockers you can give. And then stable wide QRS complexes, you can give adenosine only in if it is regular monomorphic, otherwise you give procainamide, amiodarone and sotalol. Then cardiac arrest in pregnancy in ACLS, like 2 to 3 points I want to remember here. Airway is very important. In cardiac arrest in pregnancy, airway has to be taken, very important. Administer 100% oxygenation, avoid oxygen management, avoid excess ventilation, and perform airway management is very important. High quality CPR. And left uterine displacement, lateral left uterine displacement, is important. Perimortem cesarean section, unfortunately, if the mother is not able to be revived, then perimortem cesarean section has to be done in 5 minutes. This is one of the most important change when compared with the earlier where it was mentioned 4 minutes. Now they made it clearly to 5 minutes. This is again important change I want you to remember. Okay, and then if you see the most important changes when compared with 2015 to 2020, early initiation of CPR by lay rescuers even in case of doubt, early administration of epinephrine, you can take real-time audio-visual feedbacks, physiological monitoring of CPR quality can be done by arterial blood pressure or ETCO2, IV access is preferred over intraosseous, and multimodal rehabilitation like for physical, neurologic, cardiopulmonary and cognitive impairment has to be done. In pregnancy, because pregnant patients are more prone to hypoxia, oxygenation and airway management should be given priority. And for maternal resuscitation, fetal monitoring should not be done during the cardiac arrest and when you are resuscitating. When mother achieves return of spontaneous circulation, keep the mother in TTM. During TTM, you can do the fetal monitoring. This is important. Again, to consolidating the changes, 2020 CPR guideline changes, chain of survival, recovery component added in both OHCA and IHCA, multimodal rehabilitation assessment and treatment is there. Lay rescuer should start in CPR even in case of doubt, should not delay in starting CPR while checking carotid pulse, emphasis on use of epinephrine as soon as possible, audio-visual feedback, emphasis on AV feedback regarding the effectiveness of CPR, and physiological monitoring like arterial blood pressure monitoring and ETCO2 can be used, and debriefing has to be done when needed. Then cardiac arrest in pregnancy, pregnant female are more prone to hypoxia, oxygenation and airway is given importance. Ideal position for CPR in pregnant females is supine position with left uterine displacement. Perimortem cesarean delivery should be performed if patient fails to return in 5 minutes. Earlier it was 4, now it is 5. Fetal monitoring is not done during resuscitation, but if pregnant female is comatose, TTM is followed and fetal monitoring is done in TTM. And one important point I want you to remember here is what happens in the changes in the adults, though it is discussed in your pediatrics. The respiratory rate in infants and neonates, this is one of the important change. Infants it is 20 breaths per minute, neonates 30 per minute. This is the change in 2020 guidelines, and this is also the question asked from in the All Institute of Medical Sciences immediately after this guidelines. Very important. This is the respiratory rate in infants and neonates. I want you to remember. Okay. Then coming to poisonings, arganophosphorus poisonings, corrosive poisonings, these are all important. Arganophosphorus poisonings inhibit acetylcholinesterase, leading to overactivity of parasympathetic nervous system. Clinical features mainly sludge, salivation, lacrimation, urination, gastrointestinal upset, defecation, and emesis. So as well as like muscle weakness, respiratory distress, convulsions, loss of consciousness might be there. Chronic symptoms may be when due to repeated exposure, peripheral neuropathy, cognitive impairment, and psychiatric disorders. What are the investigations? Though there will be a list of investigations, but again, the diagnosis is usually by getting the history and by clinical or physical examination. Okay, though theoretically you can do all these things like plasma cholinesterase, like decreased plasma cholinesterase levels are seen in OP poisoning, red blood cell acetylcholinesterase, which is more specific, toxicology screening and additional investigations, but you will get a fair idea by with the history and taking the proper physical examination. See this diagnosis, clinical the diagnosis of clinical based on history, especially history of exposure and characteristic symptoms and signs. So this is very important diagnosis. Then coming to the management, the decontamination, remove the patient from the source of exposure and decontaminate skin and clothing. Ingested poisoning can sometimes be removed by gastric lavage or activated charcoal, and atropine is used to reverse the muscarinic symptoms of poisoning. It's given IV. Then pralidoxime is very important. Pralidoxime is an antidote, 2 p.m. This is an antidote that reactivates the acetylcholinesterase. It is best if it is given effectively. If you can give it as early as possible, the effect will be better. Then if the patient patient is having seizures, you can give benzodiazepines, and then supportive ventilation, supportive treatment like fluid resuscitation is all normal. So decontamination, atropine, praldoxim is one most important thing, and then benzodiazepines if convulsions are there. Then coming to corrosive poisonings. Corrosive poisonings may be acids or alkalis. See, which is more dangerous, acid or alkali? If you see, acid cause coagulative necrosis and alkali cause liquefactive necrosis. So corrosive substances including acids, alkalis, and some other chemical cause tissue damage and contact. If ingested, they cause severe damage to the gastrointestinal tract. Immediately there will be pain in the mouth, throat, chest or abdomen, and this is often the first symptom after ingestion of corrosive substance. Majority of the people will spit from there, but again the injury will be there. The mouth and throat damage, so if they spit it from there, there will be mouth and throat damage, may include burns around the mouth, drooling, difficulty in swallowing, and hoarseness or loss of voice. If it goes inside, like nausea, vomiting, pain abdomen, and bloody stools can occur. And sometimes if there's a perforation of stomach or intestines, it can cause peritonitis. Then if the fumes, like respiratory signs may occur if there's fumes are inhaled, like shortness of breath, cough, chest pain, and even respiratory failure. So again, the diagnosis is predominantly by the history and physical examinations and history of exposure and clinical symptoms. Eventually, like to see what is the extent of involvement, investigations of the endoscopy can be done 24 to 48 hours after ingestion. By the time, like swelling will slightly be decreased. And imaging, if the X-rays or CT scans to see whether there is any perforation. Then lab tests include the rest of this incomplete blood count, electrolytes, and all. Management, supportive care is the mainstay of treatment and includes pain management, maintaining a patent airway, and monitoring for complications. Here, very important. Neutralizing agent, because acid is given, don't give alkali, or alkali is there, don't give acid to neutralize that. When acid and alkali react, they cause neutralizing reaction, which forms which is an exothermic reaction. That means heat is produced, so you can't use this. So as they can exacerbate injury due to the heat generated by the neutralization reaction. And another important point, so gastric lavage is contraindicated, and emesis, trying to bring out emesis or like vomiting is contraindicated. Emesis induction is also contraindicated. Very important. So endoscopy is not only diagnostic, but also it can be used for therapeutic, like if the strictures are there, like to vasodilation and all, for endoscopic dilatation. Surgery in case of perforation or severe stricture. Antibiotics prophylactically you would use unless until you feel that there is a perforation or risk of aspiration. In this, I want you to remember one important point: the supportive care is the paramount. Neutralizing agent should not be used because they exacerbate the neutralization reaction. Gastric lavage is contraindicated. Emesis induction is contraindicated. Okay, again to emphasize this, initial resuscitation aims to manage aggravation of injuries and treat potential systemic complications. Basic is maintenance of airway and circulation. So if there is a laryngeal injuries, you can go for tracheostomy. Contraindicated, what is this? Keeping the patient in supine position, because whatever the thing, it may come back again, the esophageal injury can occur. Gastric lavage is contraindicated. Induced emesis, these all things are contraindicated. Neutralization of acids with alkali or vice versa is contraindicated, as heat generated could aggravate tissue damage. And sometimes people may say like we'll keep milk or water, but again this is not so I mean, there's no proper studies on this. Then supportive care is what you do that. And IV proton pump inhibitors, if it is like more damage, you can give that. And corticosteroids are not much of an they do not prevent the development of strictures following corrosive ingestion, and particularly when the airways are involved, in those conditions only you will use this. Routine use of broad spectrum antibiotics is not recommended except in patients with high grade injuries and receiving systemic steroids. So here I want you to remember these things: supportive management, gastric lavage, emesis induction, supine position contraindicated, neutralizing agents are contraindicated. Then these next two slides can bring you at least 2 points: the poisoning type and their antidotes. So organophosphates, this is the praldoxim and for organophosphates, the antidotes are praldoxim and atropine. For paracetamol, N-acetylcysteine. For benzodiazepines, flumazenil. Opioids, naloxone. For iron, deferoxamine. Ethylene glycol is fomipizole or ethanol, and sodium bicarbonate in case of acidosis. Methanol, same, fomipizole and ethanol, and sodium bicarbonate in acidosis. Cyanide, hydroxycobalamin and sodium thiosulfite. Carbon monoxide, oxygen, and sometimes you can give even hyperbaric oxygen. Snake bite, we'll discuss about this, is a polyvalent anti-snake venom. Scorpion sting, scorpion antivenom. Aluminum phosphide, usually used in pest control. No specific antidote. Supportive treatment include IV fluids, vasopressors, gastric lavage, and magnesium sulfate. Rat poison predominantly acts on the liver, like because anticoagulant composition is there, so vitamin K1 has to be given. Then lead the antidote is dimercaprol, succimer, penicillamine. For mercury, dimercaprol and succimer. Arsenic, dimercaprol and succimer. Copper, penicillamine. Digoxin immune antibodies. Beta blockers, it is very important, glucagon. Calcium channel blockers, calcium, insulin, glucagon. Tricyclic antidepressants, it cause acidosis, metabolic acidosis, so sodium bicarbonate. Black widow spider bite antivenin you use. Pesticides, non-organophosphate pesticides, no specific antidote, but activated charcoal may be used to bring it. Aspirin, it cause again acidosis, soda bicarbonate is used. Alcohol, ethanol overdose or supportive care. Thiamine B1 and pyridoxine B6 can be used. Amphetamines, benzodiazepines for symptomatic management. Methemoglobinemia caused by nitrates or local anesthetics like prilocaine mainly. Methemoglobinemia which is caused is treated by IV methylene blue. This is very important. These two tables I want you to see every alternate day for a couple of minutes. So by seeing for the next 15 days or every alternate day, by seeing 7 times, that's hardly you spend 15 minutes on this overall, and 2 questions are there in your pocket for sure. This is what you want to do this. Then coming to other topics, there are like other topics. Then I said, okay, one second. Other important topics like acute pulmonary edema, acute exacerbation of COPD, pulmonary embolism, and then come to hyperkalemia, ARDS, and important points about this: ischemic stroke, hemorrhagic stroke, septic shock. What are the surviving sepsis guidelines, and what are the ARDS net protocol? Then anaphylactic shock. How do you management? Then snake bite. In snake bite management, the first hour is the golden hour. Whenever possible, first dose of AH2 must be given in the first contact itself. So what are the in the community level, what it has to be done, and what is the referral criteria for vasculotoxic, that is envenomations, and what are the referral criteria for neurotoxic envenomations, and this is what is the neck lift sign. Neck lift is the broken neck sign is observed in this when a kid is with the Russell's viper or any cobra or crate which has progressive descending paralysis. When to do that, when to refer, these things are important, and how to handle the tourniquets, how slowly you have to do that, and for if there's a pain, oral paracetamol or tramadol has to be used. Aspirin and NSAIDs has to be avoided. Then ASV is the mainstay of treatment. In India, it is polyvalent ASV. In India, it is polyvalent ASV. For individual snakes, there is not. So when you are not sure about which snake, still go ahead and administer the polyvalent ASV, because all the 4 main 4 common species: Russell's viper, common cobra, common crate, and saw-scale viper is covered with this. Then what is the dose you give? Any prophylactic you give it. Prophylactic you usually with hydrocortisone 100 mg and antihistamine, or 0.25 to 0.3 mg adrenaline subcutaneously you give it. Then very important, what is the ASV dosage? For neuroparalytic snake bite, ASV 10 vials start as infusion over 30 minutes, followed by second dose or 10 vials after 1 hour if no improvement within 1 hour. So initially start, you give 10 vials over 30 minutes, followed by second dose of 10 vials after 1 hour if no improvement in first hour. For vasculotoxic snake bite, there are 2 regimens: low dose infusion therapy, high dose intermittent bolus therapy. So what you do is, in both these things, for Russell's viper 10 vials and saw-scale viper 6 vials. So remember, about most important is Russell's viper. 10 vials you give it bolus over 30 minutes, followed by, in the low dose, 2 vials you keep giving every 6 hours as infusion in 100 ml normal saline till the clotting time normalizes for 3 days, whichever is earlier. And here in high dose, what you do is 10 vials you give it 30 minutes, similar to that, followed by 6 vials 6 hourly as a bolus therapy. So here there is something called WBCT, whole blood clotting time and all, which is important. And then no ASV for no need of ASV for sea snake bite or pit fiber bite are available. So in the more important points about like hyperkalemia, acute pulmonary edema, septic shock, anaphylactic shock, hyperkalemic management, all these things like the critical care components and other emergency medicine topics are in length in the ADrPLEXUS app. You can go through that in this Target UPSC CMS app. If you see this, so this is Combined Medical Services Examination UPSC CMS, where you can see Target UPSC Sure Success module. We have 50 hours of videos, highly crispy, concise, revised videos, which in this 50 hours, of videos, we ensured that all the things, all the topics. We curated these topics and these videos in such a way that these are directly taken from the UPSC syllabus, and last 5 years we have analyzed the question papers, and based on those, these videos have been curated. This 50 years, by watching these 50 videos, it can give you a fair advantage, and you will be having that head start, and it will be crisply. And we had developed this 100 hours UPSC CMS hackathon study planner, where in this 100 hours for 10 days, how you can do that based on date, what videos you have to do in the morning, and then you take the examination, which examination you have to do, and explanation when you have to do that, and then videos, like the second set of videos, and how you revise it. And after that, in addition to the previous year question papers with the beautiful explanations and the crispy, concise videos, the final revision planner, which includes the 3 mock tests and how you can revise on that. So with this 100 hours planner, this 100 hours planner of UPSC CMS hackathon study planner gives you a fair advantage, and we're pretty much sure from this 50 hours of videos, by spending this total of 50 hours of videos and following our study schedule for 100 hours, that can fetch you from wherever you are, like additional easily, like 100 points from where you stand it. Even for those who didn't study and like just watch these videos and attempt this 100 hours, still there are high chances that you can get into this. These are being curated based on, exclusively based on this question papers. I mean this syllabus and previous year question papers. Okay, which has been there. We have PSM, we included even for OG, obstetrics, gynecology, family planning, and all other surgical components, and traumatology, medical legal issues, and all these things have been covered, and pediatrics and medicine, emergency medicine. We also covered critical care medicine, few topics, snake bite and common poisonings and all. And you can get it through ADrPLEXUS, the website. You can subscribe it, and you can see we are giving this question bank and videos at 3,999 rupees. And you can one thing is for sure, by going through these videos, this is very meticulously designed, and this 100 hours can give you a phenomenal start and the confidence to crack this examination, guys. So these question papers have been included, and what are the practice papers, all these things is there. So this is the planner, and please stick to the 100 hours hackathon planner, and this will give you a sure shot success, guys. All the very best, and all the very best. And so you can log into the ADrPLEXUS app, and you can do that. For there's a special prize for those who subscribe before tonight, and all the very best for your UPSC examination, guys.